Let's join Dr. William Geiger for a discussion on common neurological disorders.
So again, I have nothing to disclose. Our learning objectives today, we're going to talk about seizures, we're going to talk about vascular headaches, we're going to talk about multiple sclerosis, and we'll start with a case again. A 65-year-old male patient of yours presents to the ED having had a seizure in his bedroom witnessed by his wife. She heard a cry and the fall, saw him stiffen, shake all over, and then become incontinent of urine. He was not arousable until he had been in the ED for several minutes. His seizure would be classified as complex partial, generalized tonic-clonic, grand mal, or myoclonic. Please go ahead and mark your answers here. Well, good. Most of you got that this is a generalized tonic-clonic. The old-fashioned terminology is grand mal. Those of you of my generation, that's what they were called when we were in school. First of all, a seizure. A definition of a seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, and synchronous neuronal activity in the brain, and it can either be focal, or partial is the other term for that, or generalized throughout the brain. So the seizures are classified as either focal or generalized, and focal seizures include just those that are localized to one part of the body. The arm just shakes, the leg just shakes, or with ipsilateral propagation, it starts in the arm and then moves to that entire side of the body. Contralateral propagation, or secondarily generalized. It starts in one specific area, then the seizure becomes generalized. Older classifications used to talk about simple or complex partial seizures having to do with whether the patient lost consciousness or not. With the newer classification, that has been thrown out. Generalized seizures are either those that are called non-convulsive. These are the old term is absence. You'll still hear neurologists using that term. The typical non-convulsive generalized seizure is what used to be called petit mal, has that specific classic finding on the EEG. There are other atypical types. And then convulsive seizures, there are several different classifications. The far and away most common is tonic-clonic, where they stiffen and then shake. But there are others, as you can see, that we've listed there. Okay, the most likely cause, the same case, the most likely cause of your patient's seizure would be cerebrovascular disease, stroke, idiopathic, metabolic derangement, or brain tumor. Mark what you think. Okay, a learning point here. The answer is cerebrovascular stroke. Those of you that marked idiopathic, for all age groups, idiopathic is the correct answer. But for our specific patient, he was a senior. And as you can see, the incidence of brain tumors and strokes as causes of seizures is much greater in the senior age group. So the right answer for this patient would have been CVA. And of course, you know the definition of idiopathic. The doctor's an idiot, the patient's pathetic. Other causes of seizures, obviously head trauma, infection, cerebral degeneration, congenital brain malformations, inborn errors of metabolism. Those are, and then we need to understand provoked seizures. Provoked seizures are seizures that occur in a setting of a medical disease that if that disease were removed, the patient presumably would have not had a seizure. And those are the usual metabolic things that we think about. Problems with sugar, problems with sodium, problems with calcium, problems with the kidneys, other things like hyperthyroidism. Cerebral anoxia is a big thing that can cause a provoked seizure as well. In an urban hospital where I'm currently practicing, alcohol and drug toxicities is a major cause of seizures. Now, epilepsy is not synonymous with seizures. Epilepsy is clearly defined as a chronic condition characterized by at least 2 unprovoked seizures with at least 24 hours between them. So that's the definition of epilepsy. And then there are all kinds of epilepsy syndromes that we're not going to go into. That's the province of our neurological colleagues. Third question, your patient's complete history and physical examination is unremarkable for provoked causes, signs of infections, drug toxicities, neurological disease. The next step in your workup would include a toxicology screen, prolactin level, neuroimaging, or lumbar puncture. Go. Okay, good. Neuroimaging is the next step. This leads us to how do you work these patients up for seizures, the diagnostic evaluation. And the most important thing, as we were all taught in medical school, is the history and physical examination. And in this kind of situation, having a witness of the seizure is immensely helpful. The patient's wife saw the seizure, could tell you exactly what happened. Always ask about substance abuse, head trauma, previous strokes, heart history, sleep disorder, and do a complete drug history, including over-the-counter. Blood studies, you're going to want to do looking for provoked causes of seizures, CBC, lights, calcium, magnesium, phosphorus, glucose, BUN, creatinine. Now, I put a question mark by SED rate, liver functions, RPRs. Those would be only if you suspect those things highly. Those would not be for the routine patient. And I wanted to mention prolactin here because there was a lot written a few years back about prolactin and its use in the emergency department with strokes. That has been pretty much discredited because it has a very low positive predictive value. The main setting for using prolactin is in the electrophysiological units where the neurologists are trying to distinguish between psychogenic seizures and organic seizures. And if a patient has a prolactin level drawn within like 10 minutes of the event and it's high, that's a clue. It doesn't make the diagnosis, but it's a clue there may be something organic going on. Lumbar puncture. And again, this is a departure from when I was in medical school. Everybody who had a seizure always got a lumbar puncture. That's no longer true, only if you think that there's signs of infection. Everybody should get an EEG because you want to look for an epileptogenic focus there, and that'll help guide your treatment and diagnosis. Neuroimaging, obviously MRI is preferred over CT because you're looking for masses, not so much blood. And of course, the question always comes up if you find something, is that what's causing the seizure or an incidental finding? So your workup progresses, it's completely negative. You diagnose an unprovoked seizure. Your first step in treatment would be IV phenytoin, oral valproic acid, or no medications at this time. Well, good. You got the right answer. Overwhelmingly, start no medications. And again, that is a departure from the past. I remember, and I'm an old guy, so I remember those days when everybody got Dilantin and phenobarb, the first seizure that they ever had. That has really fallen out of favor because of all the side effects of these anti-epileptic drugs. So don't give it for just a single isolated seizure like this patient or infrequent seizures. Now, the recommendations are you should give it if there's a high chance of recurrence of seizures. And I've listed here for you what are the risk factors for that. If they come in status, if they've had a brain injury, if you find a brain lesion on the scans, all of these things would be reasons to start on medications. And if there's an epileptogenic focus on the EEG, you probably should too. And if they have any of these types of seizures, these tend to recur. So you'll want to treat these after the first one as well. Any partial seizure, absence seizures, etc. Now, anti-epileptic drugs. The recommendation now is start with monotherapy. Just one drug. Choose one drug, and there's not one drug of choice. There are many out there. Your decision is based on the type of seizure, the other medications the patient's on that may be affected by stimulation of the cytochrome P450 system by some of these meds, comorbid conditions, and nowadays more and more I find it's determined by what their insurance is going to pay for, which eliminates a lot of the higher priced, newer anti-epileptic drugs. The recommendation is you try 2 monotherapy trials before you try combinations for your patients, and monitor them closely for effectiveness, for side effects, and compliance. A general classification of anti-epileptic drugs: broad or narrow spectrum. Are they for all seizure types or certain types, focal seizures of certain types? What about generation? The first generation drugs are the ones that are cheap, but they also have a lot of side effects. Even foods interfere with those. The newer drugs, the second generation, their claim to fame is that they have a lot fewer side effects, a lot fewer drug interactions, but they're very costly, and often there's not good blood level monitoring available for them. What you really need to know for the exam is this slide and the common toxicities of these anti-epileptic drugs. Suicidality. There's a black box warning on all anti-epileptic drugs because the risk of suicide is higher in patients taking all of these kinds of drugs compared to placebos. We all know about the neurotoxicities, the ataxia, the dizziness, somnolence, etc. Rashes of all types, from very minor maculopapular rashes to Stevens-Johnson syndrome. And, of course, the induction or the inhibition of liver enzymes, depending upon which anti-epileptic drug you choose. Okay, another question. A 46-year-old male patient of your practice presents with fever, arthralgias, and erythroderma. He has no respiratory symptoms. His medications include lisinopril, valproic acid, and atenolol. His fever is 102.2. His skin reveals very erythematous maculopapular rash and some tenderness when you touch this rash. There are no oral lesions. You order blood work that reveals an elevated white count, 16,000, 17% eosinophils, and some elevation of AST and ALT. The most likely diagnosis is toxic shock syndrome, DRESS syndrome, Stevens-Johnson syndrome, or erysipelas. This is not a derm lecture. This is a lecture on seizures. A little clue there. Of course, you would know that on the exam. Well, good. The DRESS syndrome, good. When I first started using this question, few people knew about that. So obviously the word is getting out about the DRESS syndrome. It means drug reaction with eosinophilia and systemic symptoms. Good descriptor. This typically is a maculopapular rash with fever, arthralgias, lymphadenopathy, and it frequently persists for weeks to months, and it does have a significant mortality rate. So you don't want to miss this complication of these drugs. Now, the common offenders are anti-epileptic drugs, but also other drugs we use a lot of, sulfonamides and allopurinol. And I've seen 2 cases over in the last 5 or 6 years of induction by sulfonamides in a patient taking Bactrim who had the DRESS syndrome. So this is not all that uncommon. Status epilepticus is a medical emergency. It's an unremitting seizure lasting longer than 5 to 10 minutes, or recurrent seizures without an interictal return to baseline. That's the definition. And it's a medical emergency because there's a significant mortality rate for status epilepticus of 20%. The metabolic demands of repeated muscular convulsions really stresses the body, and neurons begin to die after 30 to 60 minutes of continuous seizure activity. So this is nothing to be messed around with. This is the type of thing you evaluate as you treat. The drug of choice is lorazepam, has been for some time, but other benzos work real well. And frequently you'll see them used in combination to keep these under control. Where I've been, it's usually been lorazepam and fosphenytoin together to keep them under control. What about seizures and driving? There's a lot of concern about this, but really very few motor vehicle accidents can be traced back to people having seizures while they drive. And actually, fatal motor vehicle accidents from alcohol is 8 times more than those who have seizures while they're driving. For those who do have seizures, the best predictor that they're not going to have a motor vehicle accident related to a seizure is seizure-free interval. That makes sense. The longer they go without a seizure, the less chance of having a motor vehicle accident. But the flip side of that coin is, the longer they go without driving, the longer they go without seizures, and you force them to do that, the less likely they are to not drive. Driving has become such an important part of our social and culture that to keep patients from driving is really a hard thing to do. This created a lot of concern among state legislatures in the mid-90s, and in 1994, these neurology groups came up with a consensus recommendation that anyone who has a seizure should not drive for 3 months. That's important to understand. That's kind of a nice common ground here. However, remember that your state makes the decisions about that. You don't. And there are even some states that require you to report a patient who has had a new seizure. That isn't true for most states. You need to know all your state laws. In your handout, unfortunately, I had a link there. That link is dead now. It only takes you to the Epilepsy Society, which used to have a nice page listing all the state laws. That since has no longer been on there. So you'll have to check your own state government websites for the particular laws in your state with regard to this. But seizure-free intervals are different often from state to state. What about epilepsy and pregnancy? Well, you all know about hormonal contraception and how anti-epileptic drugs stimulate the cytochrome P450. I've listed the bad actors here that interfere with hormonal contraception. So keep those in mind. Also, anti-epileptic drugs interfere with progesterone-only pills, with contraceptive rings, and progesterone implants. They do not interfere with Depo or either of the IUD systems, hormonal or otherwise. So those are good to use in patients who have seizures. As far as breastfeeding, your patients can breastfeed on any anti-epileptic drug. And oral contraceptives can actually decrease lamictal blood levels. So keep that reverse in mind. If you get a patient who has epilepsy, who wants to get pregnant, hasn't had a seizure for quite a while, you could consider stopping the antileptic drugs. I would recommend you do this collaboratively with their neurologist if they've been seizure-free for more than 2 years. If they come in and they're already pregnant on antileptic drugs, continue the drugs. Supplement with 4 milligrams of folic acid if they're on carbamazepine or valproic acid. Monitor your drug levels at these particular intervals. And then there are 5 different drugs that you should give extra vitamin K in the last month of pregnancy. And then here's my point about breastfeeding and all of them being safe except Lamictal, lamotrigine for breastfeeding. Okay, let's switch gears. A 36-year-old female comes to you for a complaint of headache that she's had for years, occurs 8 to 10 times a year. They have not changed, and they start with flashing lights in her eyes, followed by left-sided throbbing headaches associated with nausea and vomiting. She has taken over-the-counter medicines, but lately they've not been that helpful. The best initial therapy for this patient would be A, ergotamine, B, sumatriptan, C, propranolol, D, verapamil. Please mark your answer. Good. Sumatriptan, that is considered the first-line drug of choice for vascular headaches. Now, when we talk about vascular headaches, there are 2 broad categories. Migraine is one, but the other one has a lot of subcategories. Trigeminal autonomic cephalgias. Cluster headaches fit under there, but there are other types of trigeminal autonomic cephalgias. Patients can have shorter headaches than they do with cluster, occurring much more frequently. The main thing to remember is that cluster headaches are part of that group that have autonomic symptoms and not just a headache. Let's talk about cluster. Cluster prevalence is less than 1%. Not real common, but you'll see them in your practice. More common in males than females. It usually has orbital or temporal headache pain, unilateral, and it's associated with either ptosis, meiosis, rhinorrhea, lacrimation, or conjunctival injection, the autonomic symptoms. The headaches can last anywhere from 15 minutes to 3 hours approximately. And the best treatment acutely for this is oxygen and sumatriptan. I had a patient years back when I was in private practice who had cluster headaches, and he finally learned not to go to the emergency room because his headaches resolved on his own because they were short-lived before anybody could see him in the emergency department. That's one thing to remember here. Preventive treatment. Verapamil is the drug of choice, far and away. There are other things, steroids, lithium, topiramate, methylsergides on your handout, but I decided to eliminate that on the slide because it hasn't been available for a number of years. Migraine headaches, more common than cluster headaches. 12% of the population is affected, and female predominance compared to cluster headaches, where males have more. And if you go and you review the literature on the pathophysiology of migraine headaches, you'll come up with pages and pages and pages and pages and pages of studies. And I found as I review the medical literature, when you find that sort of phenomenon where there's a whole lot written about pathophysiology, we probably don't know what in the world's going on and causing it. It has something to do with permeability, the blood-brain barrier, which leads to inflammation of the meninges, which leads to vasodilation. And other things like genetic factors play a role in this, no question about it. But regardless of pathophysiology, we can understand this and treat it. Migraines occur typically in 4 phases. The prodrome. Many patients will tell you that I know the day before when I'm going to have a migraine headache. I'm depressed, or I'm anxious, or I'm euphoric, or I'm yawning, all kinds of different things. If they're going to have an aura, they have that. That's the second stage, and we'll talk a little more about that. Then they have the headache, and then there's a postdrome, where they don't really have a headache, but they are still recovering, and sometimes frequent head movements can cause some pain. Now, here's some pages you should review for the test. The International Headache Society, their diagnostic criteria for migraine. This is important to remember for a couple of reasons, but first, migraine without aura. Headaches last 4 to 72 hours, and they have 2 of these 4 criteria: unilateral throbbing, moderate to severe intensity, and worsened by physical activity. And then they have 1 of the next 3, photophobia, phonophobia, or nausea and vomiting. And then I think the most important thing here, no evidence of other underlying disease, neurological disease specifically. These criteria, you'll see in a minute why it's important to make sure that your patient either fits or doesn't fit these criteria. Migraine with aura, the headache is the same descriptor. The aura is defined as transient neurologic symptoms. Transient is the most important word there. They come on gradually over 5 to 20 minutes. They last less than 60, and the headache starts within 60 minutes after the aura clears. There are many types of auras. There's the classic visual aura with flashing lights, spots, or whatever, other sensory dysphagia. But the key point, all of these auras are fully reversible. If they're not, then you've got to reconsider your whole diagnosis. To classify someone with migraine with aura, they have to have at least 2 migraines in their lifetime where they've had the aura. How do we diagnose migraines? It's primarily clinical. It's a clinical diagnosis, and the physical examination should reveal a completely negative neurological examination. And here's where these diagnostic criteria come into play. If they fit the diagnostic criteria we just reviewed, you do not need to image these patients. You image them if they have unexplained neurological symptoms or if they don't fit the definition. And there's a nice article and patient handout on this, again, in the Choose Wisely campaign. Also, there's no benefit for EEG. And again, I would refer you to the Choose Wisely campaign. Here are the red flags for neuroimaging. Always remember this. This will be valuable clinically. This will be valuable for you on the test. And I have this handy and pull it out and share it with the residents from time to time. Rapidly increasing headache, a history of lack of coordination, localized neurologic signs or papilledema, headaches that awaken from sleep is a very important symptom to ask about. Patient, obviously, if it's the worst headache of their life, you got to think about subarachnoid hemorrhage. Patients with cancer, HIV, or Lyme disease, these are red flags. You should neuroimage those. If a patient's first migraine is over 50, first headache is over 50, you should image. And rapid onset with strenuous exercise or temporal artery tenderness, those are all things that require further workup, don't fit the categories we're talking about. Treatment of migraines, triptans, has become far and away the initial first-line treatment for migraine headaches. They're all effective, they're all well-tolerated, and there really have not been a lot of head-to-head studies to say which is better because they all work. So pay your money and take your choice. Sumatriptan offers probably more ways to deliver this medicine than others, and so it sometimes is the most popular. The thing you need to understand, if you don't remember anything else about triptans, remember this, that teaching your patient to take their triptan at the very first hint that they're getting a headache is the strongest predictor of success of triptans. Way too many patients that I talk to, you prescribe triptans, and even if you try to educate them, they wait, is this really going to be a bad headache? And then they take the triptan, and it doesn't work. Well, no wonder. So be sure to tell them to take it at the first hint of any problems. And I've got a list there of situations where you should avoid triptans. Ergots are still out there, but mostly we see DHE45 used in the emergency room for someone who comes in with a horrible headache and vomiting, combined with an antiemetic, usually metoclopramide. And then I put dexamethasone on here because that's an excellent way, it's been shown, good evidence, that treating patients in the acute setting with dexamethasone IV or IM reduces the rate of early headache recurrence. How about preventive treatment? When should we treat patients preventively for migraines? If they interfere with their usual activities, if they're overusing their acute treatment, their abortive treatment, or if they're having adverse effects, or if they just say, I don't like this, I just don't like taking these medicines and I want to try this. And certain migraine variants there you should treat earlier with preventive. And these are the three classes of medications. I've usually seen topiramate and beta blockers used the most, but that I'm sure varies a lot with the neurologists. Don't forget estrogen-containing contraceptives. There's an increased risk of stroke using those with any woman who has migraines with aura. So that should be a reason to seriously consider prescribing an oral contraceptives. Any woman over 35 who has migraines also, there's increased risk of stroke. Quickly, a word or two about multiple sclerosis. This is an acute inflammatory demyelinating disease, as you know, that affects young adults in the 20 to 45-year age group with a 2-to-1 female to male ratio. The diagnostic criteria of this is that you need to demonstrate discrete lesions in different parts of the CNS at least 3 months apart. In other words, 2 episodes of neurologic symptoms with lesions that explain those on imaging 3 months apart. There is really no blood test for that, only things that will support the diagnosis. We really don't understand, again, where this comes from. Something has stimulated the immune system, whether it's some sort of viral infection or something genetic. But there's more and more better treatments for this. Clinical manifestations, it can be insidious onset, it can be sudden onset. Optic neuritis is a common symptom in multiple sclerosis, as you know. Usually sensory symptoms are a common presentation. There can be motor symptoms, but usually those are later. Bladder urgency and retention is a symptom. Constipation, sexual dysfunction, fatigue, and depression. All of those are symptoms of this disease. Lermite sign is present in multiple sclerosis, and that's rapid flexing of the neck causes an electric shock feeling down the legs and the arms. And Utop's phenomenon is a person who would sit in a hot tub or a hot bath, and their symptoms get worse. The disease patterns, the most common is the relapsing, remitting. It also has the best prognosis, thankfully. There are others, and as you go down this list, the prognosis worsens. Acute exacerbations of MS are treated with methylprednisolone and a short taper. Neurologists now are using disease-modifying drugs a lot earlier in this course of multiple sclerosis, much like rheumatoid arthritis. Get them on the disease-modifying drugs early. The relapse rate is decreased. There are decreased lesions on brain scan compared to those that are not on these disease-modifying drugs. They can either be immunomodulators or immunosuppressives. And I'm not going to go into detail on these drugs because I can't even pronounce these names, and we're probably not going to be prescribing them anyhow. So there we go. There are your answers, and thank you very much.